Will do. Thanks.
Perfect. All right, guys. Well, thank you very much for coming. As he doesn't need a whole lot of introduction, but those of you who don't know Dr. Floyd, so Dr. Floyd is sort of one of Georgia's probably classic hand surgeons. One of the first people doing a lot of the really complex hand upper extremity here. And those of you who have either spoken to him or hear him speak, you'll get a sense for the incredible complexity that he's sort of lived his life doing. And it's a really nice stage for all of us to kind of follow in his footsteps, and at least with regards to wanting to kind of take on some of the more challenging stuff. So he decided to come up and brave the Atlanta traffic and joined us.
Yeah, well,
join us for this on 10 transfers of the hand, and then afterwards we'll kind of open it up and Dr. Floyd, if you have any other cases you want to go through, or if you want us to sort of bring up stuff, we can.
Yeah, good, great, fantastic. Well, I appreciate the opportunity to be here. Michael, thank y'all. I went to medical school at Emory, and I have a lot of affection for this institution. And I'm gonna talk about tendon transfers today. They're a sort of classic part of hand surgery. They weren't developed until the 20th century, but the history of tendon transfers parallels the history of hand surgery, and I'll point that out as we go through. Sterling Bunnell from San Francisco. This is one of Littler's drawings of Bunnell, and Littler was Bunnell's trainee, and Bunnell's, as we know, he's the founding father of hand surgery, and he established centers for hand surgery during the Second World War and developed the concept. He was a general surgeon. He developed the concept that the hand surgeon should be facile with all organ systems in the hand. So we have orthopedic and plastic surgeons here today. The cadre of young surgeons treating the wounded warriors made his concept for the young specialty a reality. In his book of Surgery of the Hand, published in 1944, popularized many tendon transfers, and we'll show some things from that book today. Along with trauma, the management of polio prompted the evolution of tendon transfers. Ed Irwin was a trainee of Michael Hoke, the first orthopedic specialist in Georgia, and succeeded Hoke as the medical director for the Institute for the Treatment of Infantile Paralysis in Warm Springs, Georgia. He founded the Georgia Orthopedic Society and was the first Georgian who was a member of the ASSH. He was a close friend of Franklin Roosevelt. There he is seated on Roosevelt's left at a Thanksgiving dinner. So ASSH presentations in 1950 and 51 from the Georgia Warm Springs Foundation were authored by Dr. Irwin and National Infantile Paralysis Fellow Leonard Goldner in 1950 on an analysis of paralytic thumb deformities. And Don Eiler, who became a Nashville hand surgeon, and both Doctors Goldner and Eiler would become ASSH presidents. My father trained under Ed Irwin, and a school of hand surgery developed under Dr. Goldner with such luminaries as Gelberman, Komen, Urbanic, Nunley, Lamar Fleming, and many others. But they had the root here in Georgia. So another school of hand surgery was led by Bill Littler. He was a founder of the ASSH. And this paper on the management of combined median and ulnar paralysis was presented at the 1948 ASSH meeting. And as we talked, I'm one of his last fellows, and I'll use many of his drawings in this talk. Now, I was a resident under Dick Smith, Dick Smith was the best teacher that I ever had, and I told him that before he passed. And he was trained by Emmanuel Kaplan and Joseph Boyes. When I was chief resident at the Mass General, one of my jobs was to invite grand round speakers, and Paul Brand had just written this book, Clinical Biomechanics of the Hand, which is the basis for a lot of tendon transfers. And Dr. Brand was born in India to missionary parents, and he trained in the UK. And after the Second World War, he returned to India, where he cared for patients with Hansen's disease. He pioneered the development of tendon transfers and determined that most injuries in Hansen's disease were due to pain insensitivity. And he co-authored The Gift of Pain, which I recommend to you, and published books on Christianity, biomechanics, and seminal manuscripts on tendon transfers. Dr. Brand, Dr. Smith, Jesse Jupiter, Bob Luffert, and I were dining together at the Harvard Club on Comm Avenue in Boston when Dr. Smith had the seizure that heralded the glioblastoma that ended his life prematurely. And at that time, he was writing a book on tendon transfers, and he gave me the honor of finishing the book. So any mistakes in the book are mine, not Dr. Smith's. Now, the book Tendon Transfers is no longer published. I've worked to try to have it published, but there are not enough color photographs, have it republished, and the editors or the publishers tell me you can find that information in other places now. But you know, a few months ago, you could go on eBay or Amazon, and you could get a copy for close down at the bottom, $1,000. Well, I checked before I came down, and they're gone. You can't get one now online that I know of. So these thumb drives I handed out are that book downloaded. So put it in your computer, and it's still very relevant to this day. Okay, so the fundamental principle of the tendon transfer is the recipient muscle tendon unit is more important to limb function than the donor unit. And the relocation of a functioning musculotendinous unit to replace an injured or poorly functioning muscle thereby provides a more equitable distribution of forces in a disabled limb. And we know there are multiple alternatives. Sort of the sexiest one at this time are the neurotization procedures. And those procedures, many of them need to stand up to the results of tendon transfers. I saw recently there was a debate among residents on one of the ASSH video, what do we call them? Yeah, right. So the donor tendon must be functioning. It must be expendable and have appropriate work capacity and appropriate excursion. So, and other principles were laid out in 1921 by Sir Robert Jones. Now, Sir Robert Jones, it's almost, the eponym Jones transfers are the reconstruction for radial paralysis. And you see, this is tendon transplantation in cases of musculospiral injuries not amenable to suture. I was in a deposition recently, and they were talking to me how nothing had really changed in nerve repair. And I said, well, I was just looking at a paper from 1921 where they were only doing tendon transfers to the radial nerves that didn't work well with suture. But he outlined the principles that it is fundamental that the transplanted tendon should be kept in relaxation. That means to me resting length. It should form a straight line from origin to insertion. It should be neatly and securely fixed in its new insertion. It should not be expected to act if passed through cicatricial tissue. We just showed a case a few minutes ago. It should not be expected to correct deformity or to move a stiff joint. It should not be transplanted unless it has normal tone. I love this. These axioms may seem to be platitudes, but their observance or disregard constitutes just the difference between success and failure. So function is a key determinant. Thumb and digital extension, and in fact, opposition don't require much strength. They're positioning, they are positioning functions. Grasp requires greater strength. And one must always, factor in the strength of the antagonist, and remember that strength decreases one grade with transfer. And that particularly becomes evident when you have a patient, when you have a situation where you have reinnervated muscle, which has already maybe a grade lower, and then you're asking that reinnervated muscle to drop another grade. So muscle force is proportional to transverse cross-sectional area and independent of muscle length or excursion. Now, this is something that shows up on test. I'd look at it. It's the Blix curve, and it's a summation of two tension length curves, one for active contraction and one for elastic recoil when plotted against resting muscle sarcomere length, demonstrating the greatest force generation is when muscle is stimulated at its resting length. That is when the actin and myosin are maximally overlapping. And the first curve is active contraction versus length, where the second curve, the passive stretch, is elastic recoil, and the point of maximum tension is at the resting length of the muscle. You will see that on exams. That okay. Amplitude is the total excursion of muscle from its length with traction to its length with electrical stimulation. So here's something else that'll show up on test. Amplitude of the FDP and FDS is 7 centimeters. EDC, 5 centimeters. The wrist flexors and extensors, 4 centimeters, and brachioradialis, 3 centimeters. The wrist tenodesis effect adds 2.5 centimeters of excursion. So if you have a patient who's had a wrist fusion or a stiff wrist and a rheumatoid arthritic, and you want to transfer to the extensors, you're best off using, based on this principle, one of the FDS tendons with a 7 centimeter of excursion to make up for the for the loss of amplitude with the stiff wrist. So those of us who took physics, I think we all did, we know that work equals force times distance, and it's directly proportional. The work capacity is directly proportional to both cross-sectional area and muscle fiber lengths, and directly proportional to muscle mass. So these are principles of tendon transfers. This is from an instructional course that Dr. Smith and Hill Hastings, another one of his residents, did back in 1980. And it's a way to analyze a disabled limb. Basically, you make a list of what works, what is available. For instance, you always have to leave, you always should leave a wrist flexor and extensor. You can't take both the flexor carpi radialis and the flexor carpi ulnaris, or you'll end up with a hyperextension deformity. You have to know what is needed. You match available muscles with requirements. You think of alternative procedures such as MP arthrodeses, wrist arthrodeses, and you stage for post-op position. So phase is an interesting concept, and muscles tend to be easier learned when they're in phase. When you palmar flex your wrist, your fingers straighten. So the EPL and the digital extensors are in phase with the wrist flexors, whereas with wrist dorsiflexion, the digital flexors are in phase with the digital extensors. We mentioned you should not expect a transfer to both extend the wrist and straighten the fingers. Each transfer should have a single function and retain a wrist flexor and extensor. Okay, so we're going to shift to tendon transfers for radial paralysis. This is a Littler drawing showing the pronator teres transferred to the ECRB, and you'll note he's got the hand of God from the Sistine Chapel and the hand of man, the weak hand of man with the radial paralysis. And tendon transfers for radial paralysis remain among the best, frankly. So the Jones transfers we mentioned, it's pronator teres to ECRB for wrist dorsiflexion. Jones described both flexor carpi radialis and flexor carpi ulnaris to the extensors. Usually we don't include the EIP in the transfer, we include the EDC. And then for the little finger, we test the EDC, which frequently is deficient in the little finger. And when that's the case, we transfer into the EDQ. And then he promoted palmaris longus to extensor pollicis longus. He does not sacrifice a digital flexor, although if you don't have palmaris longus, an FDS is a good substitute. You do not have independent digital extension with the Jones transfers, but both FCR and FCU are in phase with EDC and easily learned. So there's been a debate over the years over, do you prefer FCR or FCU? Very good hand surgeons use one or the other. My training was that flexion ulnar deviation is lost with the FCU transfer, and that is with dart throwing motion or swinging a hammer is compromised. As we mentioned a few minutes ago, this is a positioning transfer, and FCU has twice the strength of FCR, so you're squandering wrist flexion strength. You need FCU to open a door or turn a screwdriver with wrist flexion and ulnar deviation. So I prefer FCR. I also prefer FCR through the interosseous membrane. It's a direct shot. It's puts you right where you need to be. I learned that from Avram Formson on the Hand Society listserv about 15 years ago, and I've been using it since, and it's a good technique. Okay, other transfers for radial paralysis were popularized by Dr. Boys. We saw a drawing of him a few minutes ago. He was from LA, and one of the few early members of the Hand Society that was not in the Army. But he uses the pronator teres ECRB, as is the case in the Jones, but he uses the FDS, the middle finger FDS to the EPL and index extensors, and then the ring finger FDS to the ulnar 3 digits. You get some independent extension with this. You lose some grip strength, and as FDS is out of phase, this transfer may be difficult to learn. But if you have a patient who is doing keying or activities that need independent extension, it's a good alternative. Here's a case harvesting the middle and ring FDS, and you can see the window I've made and the interosseous membrane, radial to the AIN, the anterior interosseous neurovascular structures, and bring those tendons back into the forearm wound, and then take them dorsally. And there's the juncture to the ulnar 3 digits. And this is the what was gained on the table. Normally with the radial transfers, you do the pronator teres transfer first, and you place the wrist where it's static in 30 degrees of dorsiflexion, and then you do the digital transfers so that they're at rest with the wrist in dorsiflexion. They're in about 30 degrees of flexion. You know, Wallet has changed some of these recommendations, but that's the classic teaching is as I described. You want with wrist palmar flexion, you want the digits to be able to completely extend, and with dorsiflexion flex, you need to be careful that you respect the digital cascade. It's nice to leave a little lag in the ring and little so you don't end up with this. And I use a sandwich technique, split the FCR and suture each tendon independently. Okay, so we're gonna shift gears now and go to restoring thumb opposition. This involves paralysis of the abductor pollicis brevis, the opponent's pollicis, and the superficial flexor brevis. With opposition, the thumb pulp needs to be placed parallel to the middle finger pulp so that they're both in the same plane. And opposition requires thumb abduction, flexion, and pronation. A basic principle is you first correct the first web contracture. Positioning requires little force, and the effective transfers for opposition approach the APB insertion from the pisiform at 45 degrees. For patients with a hypermobile first MP joint, arthrodesis may be necessary. Now here, here are 5 opposition transfers. The EIP to the APB, popularized by Burkhalter. Bunnell's transfer, the ring FDS to the APB. Kamet's transfer, Huber transfer, and then the ECU to EPB. The ECU to EPB was promoted by Dr. Phelan, and then Dr. Henderson came along a few years later and said, do it with a tendon graft. Okay, so with the extensor indis proprius transfer, you avoid using a volar tendon that's been injured or scarred. You have somebody who's had a wrist flexor injury with a median nerve injury. You probably want to go to the top and use the EIP. You lose no grasp force. You retain FDS. There is no pulley. The ulnar aspect of the forearm is the pulley, and it just reaches insertion. So you may want to take a little bit of the extensor dorsal aponeurosis to increase the length. It's available in both high, median, and ulnar paralysis. And here's the paper by Burkhalter. He was a Army surgeon in the Vietnam War, and later the chairman of orthopedics and hand surgery at the University of Miami. So this paper is current. We're starting in the beginning, and this is the March 2022 Journal of Hand Surgery. Neil Jones, who was also who was a Richard Smith Fellow, published this modification of the Henderson extensor carpi ulnaris transfer. And basically the modification is he puts a distal tendon graft into APB, not into the EPL dorsally. But he promotes it for situations where other tendons, other choices may not be available. This was amputation. That thumb was replanted, and he did not want to take FDS. EIP wasn't available, and in this case, he used the ECU tendon lengthened with a tendon graft. This is, when I want a good result, this is the one I do. The Bunnell transfer with ring finger FDS, FCU pulley, no hands is the most predictable result. It's a good vector. You've got plenty of excursion. It's long enough so that you can do a dual insertion in the abductor brevis tendon and the dorsal tendon tissues. It's unavailable in a high median paralysis, obviously. So we're going back now. Here's the paper by Goldner and Irwin we talked about in 1950, and they're harvesting the ring finger FDS. This is for a polio case. And you'll note that on the right, they're doing the insertion of the tendon in the radial aspect of the thumb. They have a pull-out button on the ulnar aspect with the thinking that that approach increases the pronation of the thumb. There are many now who would say, well, that's not true because it's really the tangent at which the tendon first strikes the metacarpal is the best you're going to get. But there are many who would take the tendon ulnar. The Kamet's transfer, or the palmaris longus to abductor pollicis brevis, is something that's been promoted as useful with severe end-stage carpal tunnel syndrome, because you're elevating the palmar fascia when you do the carpal tunnel release. It is an abductorplasty, not an opponentsplasty. It abducts the thumb, but does not pronate because it does not approach the first MP joint at 45 degrees from the pisiform. And then this is a little drawing of the Huber transfer, abductor digiti quinti to abductor brevis. It's an elegant procedure. It recreates the thenar bulge, and it can be used in combined median and radial paralysis. You elevate the abductor quinti from the hypothenar muscles. It works best if you elevate the muscle with a small strip of FCU and elevate it from the pisiform, and be very careful about the neurovascular bundle there. So this is a 2-year-old with first web syndactyly. I actually sent her up here to Emory to see see Dr. Blackston, Dwayne Blackston. I don't know if he's still around. He taught me. He was a geneticist in the pediatric department because this can be associated with some the cardiac issues. But she was otherwise healthy, so did this first web syndactyly release when she was 2, and then here she is at age 6, and she doesn't have much of a first web, and her thumb is resting in the plane of the hand and functioning poorly. So I added a little more skin graft to the first web and did the Huber transfer, and here she is at age 13, and she's got a good thumb. So restoring power pinch, a few eponyms. We all know the Froment sign, which is with the weakness in the adductor pollicis and the first DI, the extrinsic flexor must provide the pinch strength. So the flexor pollicis longus, and one gets this hyperflexion of the IP joint as sheets withdrawn from the hand. Gene sign is first MP hyperextension with pinch. Bouvier's sign is loss of full IP extension with MP hyperextension, and it corrects with the MP in flexion. So with a low ulnar nerve injury, there is paralysis of the adductor pollicis and the first dorsal interosseous. The adductor has the largest cross-section area to volume in the hand. It's the most powerful intrinsic muscle, and those two muscles together provide 75% of the thumb adduction force. This drawing shows that adduction is actually bringing the thumb to the palm, whereas flexion and extension and abduction and the three together make opposition. Now, one option for adductor restoring power pinch is using the ring FDS to mimic the path of the transverse head of the adductor pollicis. That's the most important part of the adductor pollicis. And the tendon is passed beneath the neurovascular structures and flexor tendons. The septum coming off the third metacarpal is the pulley. But the procedure I like, and I think you like, is the extensor carpi radialis brevis adductorplasty. This paper was written by Dr. Smith in 1983, and this involves a tendon graft through the second intermetacarpal space. It doubles pinch strength. It's preferred with high ulnar paralysis, but frankly, I prefer it anytime I want to do an adductorplasty. It's hard to beat. And then our friends here, Glenn Gaston and Gary Laurie and Shane Cook, have reported Z lengthening the ECRB rather than using a tendon graft. I think that's a good thought, particularly with the paucity of tendon tissue. And then they mention also splitting the FPL, where you bring half the FPL dorsally to mitigate a hyperflexion deformity. But they caution that in these days with people texting, that may be a difficulty if the IP joint doesn't flex. And then one has to make a judgment anytime you're dealing with intrinsic paralysis, whether the first MP joint needs to be fused or possibly the IP joint. So this is one of my cases, and basically you've got the three dorsal incisions You make a window in the base of the second intermetacarpal space. You divide the ECRB at that central incision. And the more proximal incision is you take the tendon back proximally and reroute it back dorsally over the second dorsal compartment to increase the moment arm with dorsiflexion and pinch. So we also have the options of replacing the first dorsal interosseous, doing an index abductoplasty. The transfer of the EIP to the first dorsal interosseous is not very effective, but prolongation of the abductor pollicis longus with a graft to the first PI is a good option. One can also use EPB with a graft, particularly if the first MP joint has been fused. David Siegel, he was a resident with me, he's out in Tucson, and he recommends the distal transfer to the ulnar lateral band of the index finger, brought out the radial side of the index finger to produce a flexion and supinating force so that with key pinch, you don't miss the thumb, the thumb doesn't miss the index finger. And I did it in this case. It's a good technique. You see, I did the procedure at the same time I'd done the ECRB adductoplasty. Okay, we're going to shift gears now to restoring intrinsic muscle function, which is usually due to median and ulnar nerve injuries or neurologic disease. There is deformity, claw deformity, loss of the palmar arch, weakened grip, asynchronous digital motion, loss of lateral finger mobility. So in intrinsic paralysis, the extensor is focused on the proximal phalanx, and through the sagittal bands, the MP joint hyperextends and becomes parallel to the extensor. So one has ineffective IP extension. In the normal hand, intrinsics initiate digital flexion at the MP joints, and the extrinsic flexors flex the interphalangeal joints. And with intrinsic paralysis, the extrinsic flexors act only on the interphalangeal joints. So this is the 1946 founders dinner when the Hand Society was organized. That's Dr. Littler. This is Dr. Littler. This is Dr. Boys. This is Dr. Bunnell, and to Dr. Bunnell's right is Ben Fowler. And Ben Fowler was the only formally trained, resident trained surgeon among the cadre of the surgeons in the hand clinics in World War II. Dr. Littler always referred to him as that genius, Ben Fowler. And he was in Nashville. I saw him one time at the Bellmead Country Club playing poker in his dotage. But in 1949 at the British Orthopedic Association meeting, and this is published in JBJS, there was, and this is all that was there. It's Fowler's concept. And his concept is that the extensor communis has no useful insertion in the proximal phalanges, and the inability of these tendons to extend the IP joints of the claw hand depended upon hyperextension of the MP joints. If such hyperextension was prevented by tightening of the joint capsule, the interphalangeal joints could be extended actively by the long extensor tendons. Also, tendon transplants of EPB, EIP, EDQ can be used to prevent or overcome MP hyperextension and thus promote function after paralysis of the intrinsic muscles. I mean, that's something that we basically consider just basic to hand surgery, but this was a real, back in the late 40s, that was a big contribution. So with the intrinsic paralysis, there's MP hyperextension, IP flexion, and claw deformity, and the digital extensors alone can extend the IP joints only if MP hyperextension is prevented, and that can be prevented with capsulodesis, can be with a tendon transfer passing volar to the MP joints. And restoration requires prevention of MP hyperextension and a force to initiate MP flexion. So there is the Bouvier test. There's simple clawing and complex clawing. I think this came from quoting one of your papers, Eric. And with simple clawing, you can have static tenodesis or capsulodesis of the MP joint. With simple clawing, you hold the MP joints in flexion, you can actively extend the interphalangeal joints. With complex clawing, you hold the MP joints in flexion, you cannot extend the interphalangeal joints, and that requires a dynamic transfer that's motored. And that can be done with several options that we'll discuss. There's the Zancoli lasso procedure. The Zancolis, there was a father and son. They're Argentinian surgeons who are prominent in paralytic disorders. And the lasso procedure basically loops FDS under tension around the A2 pulley, and it does not increase grip strength. It can be useful with diffuse paralysis or with limited donors. The modified Stiles-Bunnell uses the middle finger FDS. Obviously, you can't use that with median paralysis or high ulnar paralysis. You take it through the lumbrical canal to the ring and little finger dorsal apparatus with hypermobile joints. You can have a hyperextension of the donor PIP and swan neck deformity. And also, if you put in the transfer too tight, you can, I've done it, you can develop swanning in the recipient digits. Now, this drawing on the left is from Bunnell's textbook, and that's the concept of a pulley advancement. And so this paper by Leddy, who later became well known as what? Y'all know what he became well known for? There you go. That's right. That's it. Leddy, Stark, Ashworth, and Boys and they recommend for a simple clawing, they recommend static MP capsulodesis in combination with the pulley advancement, which increases the angle of approach of the flexor tendons and the moment arm at the MP joint. So Dr. Brand became concerned about the strength loss, particularly in his patients with leprosy, using the FDS as a motor. He wanted to be able to add grip strength to the tendon transfers. And he's so understated. And I met him, and he really is a brilliant but understated guy. This is the paper it was in. Tendon grafting illustrated by a new operation for intrinsic paralysis of the fingers. And this was the paper that promoted the Brand transfer. We were speaking earlier about using the ECRL through the carpal tunnel and deep to the intermetacarpal ligaments into the intrinsics or into, in some cases, into proximal phalangeal bone. The procedure can be motored by a wrist flexor or extensor. We generally don't, or at least I don't, and I'm not familiar with many people who do take them through the carpal tunnel these days. But, and this is the question you'll see on exams, you'll have a list of tendon transfers, which one increases grip strength? And it's the one that has a wrist motor. And this is from Eric's paper. And with ulnar nerve paralysis, this was in PRS in 2021, discussing basically with a positive Bouvier test, doing a static procedure, and with a negative test, doing a dynamic procedure. And this was a review of multiple articles, as I understand, and it was found that the best correction of the claw deformity was FDS lasso, and the ECRL four-tail graft was best for increasing grip strength. The pinch strength is basically the transfers we were speaking of, tendon transfers to the adductor pollicis in combination with transfers to the first DI. I show this drawing, this photograph to make the point that we pass the tendon transfers palmar to the intermetacarpal ligaments. But for the index finger, if you pass the tendon transfer palmar to the second, and the metacarpal ligament of the second web between the second and third metacarpal, one, it's running with the transfer to the middle finger, but two, you're at high risk for producing cross finger. So for the index finger, we will go to the first DI insertion. That was my training, and that's okay. So one approach that we were speaking of a while ago, if you have a patient with intrinsic paralysis, if you have, the first point is if you have median and ulnar paralysis, always correct the positioning, do the opposition transfer first and get the first web mobile. That being done, you can do the thumb surgery and the finger surgery all in one setting if you have enough tendon material. You can retain ECRB as a central wrist extensor. You can use ECRL plus a graft for the adductoplasty, APL for the index abductoplasty, and ECU for the brand reconstruction. You probably would need both plantaris to do this. Lengthening the radial wrist extensor for the adductoplasty gives you a little more tendon. Okay, with a high ulnar paralysis, first you do the extrinsic reconstruction. You can do that by providing function to the ring and little FDP, as the middle finger FDP is double innervated. You can do side to side ring and little FDP to the middle FDP, or I like to take the middle finger FDS and do a transfer to the ring and little finger. Those of us who are doing some AIN supercharging or neurotization, Susan McKinnon, you can cheat a little bit in the forearm and suture the middle FDP to the ring and little FDP. And if nothing else works, that will. So when you do the extrinsic reconstruction, you produce the claw deformity. And so between stages, one needs to do use a lumbrical bar to maintain with MP static flexion, maintaining interphalangeal extension, and then at second stage do an intrinsic reconstruction. With the proximal median paralysis, there is loss of opposition, the main deficits are loss of opposition, loss of flexor pollicis longus, and loss of index finger function, because both the index finger FDP is purely median, and so the as a middle finger has dual innervation. So the standard reconstruction for this is the brachioradialis to the FPL, index FDP to the middle finger FDP, buddy transferred, and an EIP opposition transfer. Those all three can be done in one setting. With proximal median ulnar paralysis, there's both intrinsic and extrinsic paralysis, and clawing is not apparent until the flexor paralysis is corrected. You may need to stabilize the first MP joint. The radial wrist extensor ECRL is transferred to the FDP, brachioradialis to FPL, and an EIP opposition transfer. When you do that, you produce clawing, and at second stage, use the ECU plus plantaris grafts. You would not want to use the ECRB because you'd produce imbalance of wrist extensors. With a combined high, median, and radial paralysis, the only wrist motor available is FCU. And in this case, wrist motion is sacrificed with an arthrodesis. FCU is transferred to the EPL and digital extensors. And stage 2, you can do the abductor digiti quinti opposition transfer with index FDP to middle finger FDP and thumb IP arthrodesis. Now, with brachial plexus injuries, the lower plexus uses the principles of median ulnar and sometimes radial paralysis. With an upper trunk plexopathy, there's generally no elbow flexion. There may be no digital extension, maybe no wrist extension. ECRL may be the only extensor intact, and the shoulder girdle weakness. So stage 1, you restore thumb and digital extension. And what you use, if you're going to plan to do a Steinler flexoroplasty, you cannot use FCR or FCU because they arise from the medial epicondyle. You use FDS for digital extension. And for elbow flexion, I mentioned these are the historical options: pec major, triceps to biceps, latissimus dorsi, either a pedicled unipolar or bipolar, a Steinler flexoroplasty, or a innervated gracilis or latissimus free flap. This is a good review in Hand Clinics 2016. The bipolar latissimus produces the greatest strength. The pectoralis major is cosmetically deforming, may destabilize the shoulder, and results are disappointing, and that should probably be removed from the lexicon. Triceps to biceps works good for elbow flexion, but sacrifices active elbow extension, and an elbow flexion contracture can remain over time. There are some isolated long head of biceps that are promoted, but clinical results are limited, and I don't know of no follow-up data for that procedure. The Steinler flexoroplasty is an elegant procedure. You transfer the flexopronator origin to the anterior humerus to limit the pronation effect. You put the transfer anteriorly. If you cannot do it with in the presence of weak wrist extension, or you'll get hyperflexed wrist and thumb, wrist and digit and thumb. So in that instance, you either do a wrist arthrodesis or an alternative procedure. Mayer and Green back in 1954 said if you held the shoulder at 90 degrees and you can swing your elbow into flexion with pronation, that they're candidates for the procedure. This is a lady I had who had a brachial plexus injury, and I wish I had her initial pictures, but her ECRL was intact, and that's after FDS transfers to the thumb and digits. And then I did the Steinler flexoroplasty, and she was in the office last year, and about 10 years out, that's her function. And stage 3 on those paralytic cases can be a shoulder arthrodesis. How are we doing on time? Keep going? Okay, great. I'm going to shift gears now to acquired tendon ruptures. They're usually attritional ruptures with mop-ins that are difficult to primarily repair, and they require tendon transfer or intercalary grafts. Common in rheumatoid arthritis is the rupture of the flexor pollicis longus. Sometimes the index FDP becomes involved as well from the Mannerfeld lesion. He was an Austrian hand surgeon, rheumatoid hand surgeon, who in rheumatoid arthritis, osteophytes are supposed to be in osteoarthritis, but in rheumatoid arthritis, you can get osteophytes there that can rupture flexor tendons, and you can get osteophytes over the distal ulna that can contribute to digital extensor rupture. So with the flexor pollicis longus rupture, the options are you can do an intercalary graft, you can do a middle of ring FDS transfer, or thumb arthrodesis is not a bad operation at all. I had a guy last year who came in, weightlifter, non-rheumatoid, thumb and index profundus rupture from form fruits, essentially a non-rheumatoid Mannerfelt lesion. And then we know about the distal radial ulnar joint, Von Jackson or caput ulnar syndrome. The ruptures begin in the more ulnar extensors. If you have a patient come in and the ring and little finger are down, you better not put her off till 3 months later, or the index and middle will be down before you know it. So with the digital extensor ruptures, if it's the EDQ, if the little finger's down and everything else is, all the other extensors are working, you can buddy transfer EDC5 to EDC4. If the little finger extensors and the ring finger extensors are ruptured, you transfer EIP to those two. If the little finger extensor, the ring and middle are ruptured, EDC3 is transferred to EDC2 and EIP to EDC4 and 5. And if all are ruptured, FDS transfers, although there are some who would try to transfer a wrist extensor. I have no experience with that, but it's promoted. Now, we know about extensor pollicis longus ruptures with non-displaced fractures of the radius. It does not happen with the markedly displaced fractures. It's the non-displaced where the EPL's bound down to the fracture site by the third dorsal compartment. I had a plastic surgeon come into my office last Friday, and he was trying to get up under breast tissue, popped his EPL. But the management of that EPL rupture is an EIP transfer. Dr. Littler actually would do an intercalary graft. He thought that was a more pure procedure. Got two junctures. I tend to go with the EIP to EPL. This is a distal radius healed fracture where the EPL ruptured. There you have the ruptured EPL. And this procedure was done under wide awake, local anesthesia, no tourniquet. And the point that I think that I have no data other than my personal preference is to bring the EIP back proximal to the fourth dorsal compartment like we do with the ECRB adductoplasty and transfer it dorsal to the compartment to the EPL. This is on the table actively. We're seeing more and more tendon injuries with the advent of volar plating of the distal radius. FPL rupture is most common, and extensor tendon ruptures can happen. This is a paper out of the group at the Brigham, basically discussing these grade 0 where the teardrop is the tendon, the plate's dorsal, grade 1 equal on the with the plate, and grade 2 where the plate is volar. In their study, grade 0 was associated with no ruptures. The other thing that I found interesting from this paper, and it changed the way I practice, is all of their ruptures were Acumed plates. And I have no conflict on radius plates, but I don't use that one anymore. And this, I just show this because it showed up on a self-assessment exam for the Hand Society last year that to check for hardware prominence dorsally. It's this 15-degree tangential view. It's really sort of academic since we're all using fluoro, but there's a tendon, there's a screw prominent in the third dorsal compartment, and it can certainly happen, and that EPL can rupture. This is a case that was referred to me. There's the plate in place. Doesn't look that bad, but all the digital extensor tendons were ruptured by this prominent screw dorsally. So be compulsive when you're putting these plates on. And for this patient, I ended up doing FDS transfers through the interosseous membrane. You know, it's also been shown, 2 studies, one by Greenberg and a cadaver lab model, that 75% of the length is no difference in the load to failure than to the dorsal cortex or bicortical. And the second cadaveric model, screw length, 75% of construct stiffness is similar to bicortical fixation. Those are in vitro studies, but the point is you do not have to go all the way to the dorsal cortex and you're putting on those plates. That's all I got. All right, thank you. Any
Who's got questions?
Yes, sir.
I have one question that kind of has to do with the Blix curve and the Smith's rules for excursion in the rheumatoid wrist. So if you're going to fuse a rheumatoid wrist and then do tendon transfers for extension.
Yep.
Let's say you're doing like, let's say EIP for like, multiple EDC ruptures. Would you use a neutral plate or one that has that dorsal tilt to kind of give you a mechanical?
Well, first I wouldn't use EIP. I'd use middle ring FDS, or as I just mentioned, you can do an intercalary graft reconstruction. But that's the answer to the question is I usually in that setting use a straight plate. I usually, and plates work well for rheumatoid wrist fusions when the bone's good. But the Steinman pin historically has been used, and that's obviously that's a straight position. But usually in a rheumatoid wrist, I'll say I have in young people with a bad rheumatoid wrist with no problems with extensor tendons, I have fused rheumatoid wrist using a plate and slight dorsiflexion. But it's a good point, and probably if you're having a problem with your digital extensors, I would think relatively more neutral would be better. It's a bad problem. Wrist digital extensor ruptures with rheumatoid wrist. Yes, sir. Thank you.
Do you have a preference for an opposition tendon transfer when you're doing a carpal tunnel release at the same time? So a severe carpal tunnel case with you're going to transfer at the same time.
Well, what I've done, and Clay Pimer wrote it up in a throwaway, is with an endoscopic carpal tunnel release, you can make a little incision distally, get the ring FDS, pull it back proximally, bring it back around the FCU. And I'd really think in my hands, I get the best results with that transfer as opposed to EIP. I had one case last year of a surgeon, an orthopedic surgeon who had a bad forearm injury from an auger with open radius and ulnar fractures, and a avulsion injury to his median nerve, did ORIFs and nerve grafts, nerve allografts. And then he wanted more, he wanted more soft tissue on the volar aspect of his forearm because he thought it'd make his nerve work better. And he asked me to send him somewhere for another opinion. So I sent him to Susan McKinnon. Susan said, leave it alone. So then he goes somewhere else, and I won't say where. And they did lateral thigh flap, ATL flap, anterior lateral thigh flap, and they redid EIP transfer and put a tendon graft on it and brought it around the hook of the hamate. And then afterwards, the patient had an ulnar nerve, low ulnar nerve paralysis too. So he comes back to me, Waldo, I should have listened to you and Susan. He's got this big flappy thing on the volar aspect of his forearm. And he said, now I have this ulnar nerve paralysis. Will you deal with it? And I said, okay. So, so I went in and took down that EIP transfer, and that was scary. The ulnar artery is the only thing keeping the hand alive because the radial artery had been avulsed initially and was motoring the flap. But I guess I'm saying all this in that with the EIP transfer, I think it's as good as you're going to get taking it around the radial wrist and around the pisiform. And it just doesn't seem to me, in my hands, I don't get the results with that I get with the ring finger FTS. Sometimes if I've got a little old lady in no distress or a man who's end of his work life and I want to do something simple and they have really bad carpal tunnel syndrome, I will do the Kamets. It's right there. It's easy.
Yeah, Alan Bishop, I agree. I like the too. But instead of making the little slip that you pass through, he taught me to pass it through Gien's canal.
Yeah.
Make a little incision here, and pass it out. I agree with you. I mean, I don't know. Paul, have you had good experience with the Kamets procedure?
Not with Kamets. I think it's enticing to do it since if you're doing an open carpal tunnel release because it's right there. But yeah, I don't.
I've yet to have a patient like me at all like happy with like what
it doesn't really. Yeah. Right.
It like kind of moves a little bit, but it doesn't like, I don't know.
I've done EIP and I agree in that it barely reaches there. You know, I mean, you're kind of sweating.
Yeah, you really need to go out a little bit on that.
Yeah.
Dorsal aponeurosis.
I think that the ring finger FDS is probably the best, and it's great.
Stood the test of time.
Like motion activated.
Anything else?
Yeah, Dr. Floyd,
Yes, sir.
when you're doing block correction, if you're using ECRB or ECRL and you keep it all dorsal, are you transposing them superficial to the extensor retinaculum in order to get into the lumbrical canals, or you keep them deep?
Okay, the wrist motor I use, I bring dorsal to the retinaculum.
Okay.
Yes. But for the lumbrical canals, obviously, yes, all of the transfers are going through the lumbrical, all the tendon grafts are going through the lumbrical canals deep to the intermetacarpal ligaments, except as I was showing that index transfer. You can, I found you got these old golfers that come in and they want to be able to grip the golf club, and you can do the brand transfer and they get better. With a bad with a bad cubital tunnel. We think about, I don't think about it in that setting often, but it's not a bad way. And then you have people, and the same thing for the adductorplasty, old people with a bad ulnar nerve. It doesn't have to be a young person with a nerve injury. Old people who say, they can't knit anymore because they can't, the ECRB adductorplasty can help them. All right.
Thank you.
Thank you. Thank you so much. Appreciate it. Y'all ask me, I'll come back. All right.